Okay, good morning, everyone. Today, this session is Theology Matters, a panel discussion on mental health. And our panel speakers are Dr. Chad Thompson, Dr. Louisa Olushoga, Dr. Wayne Detmer, and Dr. Martha Carlo. And so we are so excited to have them this morning to share on mental health. Thank you.
Thank you, Deborah. Good morning, everyone. There we go. Let's try it again. Good morning, everyone. That's what I'm talking about. So welcome to this talk. This is really part two of a talk that we started last year with the same title, Theology Matters. But last year we kind of had different topics listed in there. I think we started with theology of disability, and then we were going to move on to theology of mental suffering, and then maybe talk about like the meaning of health and stuff. But the conversation went so long that we really we never made it to the second topic. We never made it to theology of mental suffering, mental health. So this is sort of part two of that. And my spiritual gift is the gift of delegation. So I'm really not going to say much here, but I've got these fantastic panelists up here, and we're going to introduce them in a minute. But let me tell you a little bit about myself. I'm a family doc. I grew up about 50 miles down the river, just in a small town between Cincinnati and Louisville, Kentucky. And this year, you can Google this, if you look in USA Today rated Madison, Indiana as the #1 town in the Midwest. That's my town, okay? The whole town is on the National Register of Historic Places, the whole downtown. But I think it was around 2018, we also made another famous newspaper. We were on the Sunday cover of the New York Times. And that was for a different reason. It was the article talked about how this idyllic town also had another secret. And the secret was we had one of the highest rates of suicide in the United States, my town. I think that's a metaphor for mental suffering in the church. What you see on the outside isn't always what's going on the inside, right? And so I don't know what tradition you all grew up in. I grew up in an American Baptist church, very thankful for that tradition. I can't even say it was that I learned anything there about sort of theology and mental suffering. Maybe that's the point. I didn't maybe learn anything. And so as I was starting to read scriptures, I think that there were lots of things that happened. One thing as you enter into medical training is you start to see that some of the things that people got healed of sort of looked a lot like what we would categorize as we would have a diagnosis for today. And so that's a little confusing. Wait, was that a demon or was that a neurotransmitter? What's going on there? And so the church, I think, has had trouble. And then you've got things like Sigmund Freud enter the equation with some of his good work that he did, but also some things that were confusing and maybe not things that we would hold to as Christians. And so I think that there's a reason why the church has had difficulty talking about mental health, mental suffering. I think there's also a tendency within certain traditions to want to say, to really cling to the idea of faith as the solution, right? So if you say to this mountain, be thou removed and cast into the sea, and have the faith, even of a mustard seed, it'll be done. And so if you adopt that type of thinking about mental suffering, then mental suffering can sort of become your fault. You don't have enough faith. If you just lean into Jesus enough, it'll all be okay. But that isn't what we're experiencing. That's not the reality. And so I think that's one of the reasons we want to have this discussion today. Theology isn't just what we say about God. It's what we believe about what it means to be human. It shapes the way we understand suffering, not as an interruption, but as something that in ways we don't fully grasp. It's caught up in a larger story of creation and redemption. So we need a theology that can stay, a theology that can sit with what's unresolved. And so we've come to the conclusion here, this panel, that the first commitment of the healer is not to cure, but to care. And this work is often slow, local, and attentive. It requires us to be present to what's right in front of us, even when it's difficult and even when it doesn't yield immediate results. That kind of attentiveness is not only good medicine, but it's good theology. It's a gift to have with us three incredible physicians today. In the advertisement, we kind of talked about we wanted a clinical psychologist, and for various reasons didn't have that. But we have this fantastic panel today I'm going to introduce briefly. First, In the middle, we have Dr. Martha Carlo, deeply engaged in cultivating spaces where Christians can reflect on the integration of faith and practice. She had done work as a missionary doctor in Nepal. She's a poet, and she teaches at the Duke Center for Theology, Medicine, and Culture, and has a particular interest in Ignatian spirituality, so we're going to come back to that in a minute. Dr. Carlo is a family physician. And then the next here on my left is Dr. Luisa Lashoga. She's the director of our psychiatry program. She's going to be the director of our psychiatry residency program someday. She trained at University of Chicago Northwestern, and now she serves our patients in our homeless shelters. And so she works right there with the vulnerable in the margins and is going to bring some perspective as a person whose full-time job is to think about this. And then lastly, we have Dr. Chad Thompson, also a family physician whose work spans community health, medical education, and health justice. He is the clinical assistant professor of pre-health professions in the Honors College at Baylor University. Come on, I know there has to be. Christian? Sick 'em bears, that's what I'm talking about, yeah. So, but particularly gifted in working with undergraduates, and so we want to hear his perspective. So I'm gonna just open this up by asking what comes to mind, what do you think of, we'll start with Dr. Carlo, when we talk about mental health, mental suffering.
Okay, thanks. First, there's a lot of people standing in back in a few chairs, so I'm going to give this moment, and you can move my bag off that chair. If anybody wants to scoot up and be more comfortable, I understand why there's lots of reasons why people don't do that, but there are chairs up front if you'd rather sit. Okay, that moment is over. And I want to start by reading a poem prayer. This is written by Dr. Brewer Eberly, who works with TMC. And it's actually a prayer of the weary healer, but it sums up some of the conversations that I think we'll have about community and accompaniment. So let me just read this as we start. Lord, where have I come from, and where am I going? And who belongs beside me, and to whom do I belong? I have come from you, and I am returning to you. I flee to you when I am weary and when I am strong. My neighbor belongs beside me, the lonely one in my midst. We both belong to you. O God, give us spirits of repentance and thanksgiving. Give us eyes to see those who sit without friends this day, who wonder if they belong to anyone. Give us imagination and work to cultivate places in our healing professions in which all might remember and hope and know that they are missed when they are absent, that they have a friend and a community, and the makings of a hope and a future, confident that they belong to you. Amen. Whoa, okay. I guess I'll just leave that. Perfect. Okay. So with this framing question that Wayne set out, I'm going to respond first with my perspective, which is a little bit global and a little bit Ignatian centered on the Jesuits, and then we'll each respond otherwise. I guess first I want to say that Scripture all by itself is full of amazing mental health practices, benefits of worship, benefits of Sabbath, lament, serving others, and accompaniment, this theme which I think is growing as a sense of what we're up to. Also the importance of saying no, which Jesus did himself sometimes, and all of us in this room, I'm sure, need to be aware of and respond to, as well as forgiving and being forgiven. My story, a little bit in my connection with the Jesuits, began when I was overseas in Nepal. Early on in my career as a family doctor, I went to Nepal with a very much of a development helping perspective and worked in community health in a rural area for a long time. And there was a lot of deep brokenness. And the immediate community around me were willing to pray through that with me, were willing to help fix things, but were less able to hear my heart for just being with, which I could see the answers weren't that easy. And so that is really when I first stumbled on the Jesuits as a model, and St. Ignatius as a model for what accompaniment looks like. So some of you may not know the work of St. Ignatius of Loyola, the founder of the Jesuits, which is the largest male Catholic order in the world. But he actually is a pretty good psychologist in many ways. And this has been important to me in particular as I've thought about that. It's definitely not that Ignatius, who lived 500 years ago, got it all right from the beginning. I like to think that he had an adverse childhood experience at ACE. His mother died when he was really young. He had an attachment with a sister-in-law who cared for him. He actually was suicidal at one point in his life and was pretty open about that. And then after his conversion, he suffered from what we call scrupulosity, this sense of fixation on things out of proportion to what they were, which I think can be really contemporary in how we think about it now. And he really needed a community to remind him of the bigger history of what Christ was up to, and to listen well. So a lot of Ignatian spirituality is around this sense of God in all things and relational. And sort of a cycle between contemplation and action, allowing God creative space and then acting for justice in the world. Practicing gratitude is also a really important theme of Ignatian spirituality. If you know the Ignatian Examen, which is a daily prayer, it starts out with invite God to be present, then practice gratitude, and then moves to the next steps. We're meant to practice gratitude all over the Psalms, so many places. Pop psychology, gratitude journals. It's just so interesting that the Lord has designed the human mind to benefit from gratitude. One of his poem scriptures is, I will call back into memory the gifts I have received, creation, redemption, other gifts in particular that are mine. I will ponder these with deep affection of how I am loved, what God has done for me, what he possesses, and consequently, what he desires to give me of himself. I'm reminded, I don't know if any of you saw the movie Inside Out years ago, also great themes in that, but like the memory islands, Ignatius encourages us to create our memory islands, those places that we can return to in gratitude. And then a second aspect of Ignatian spirituality, I think that is important for us in this conversation, is it's not about rule following, but about relationship. Immensely relational and based on conversations with God, what's called colloquies in Ignatian language. And the Examen, again, includes these moments of looking back at your day in consolation and desolation. So desolation are those little interior movements that you realize you are moving away perhaps from what you are being invited into, and consolation is the opposite. It doesn't mean that consolations are, happy clappy moments necessarily. You could be invited into hard things, but you know that you are partnering with the Lord in that. And the other thing that is helpful is that the patterns of consolations and desolations can lead us to discernment, to making decisions in freedom. And a lot of Ignatian discernment is about trying to understand what are the hooks and the false narratives that can catch us in how we make decisions. So we are often, as more mature Christians, deciding between two good things and doing that in freedom. And it's really important to not do that in secret. And then I think the third point I would make is, actually, I think Ignatius could have practiced cognitive behavioral therapy. He was very good at pointing out what some of the false narratives that we might have are and how to be free of them, like pride, or, for folks in this room, including myself, feeling good about the way you're serving, that becomes a disordered attachment. So you are not free to make decisions and be fully who you are, because that sort of sense comes first. And in the Latin word agere contra, to act against those ways that false narratives and being attached to something that is not the best can control you. So paying attention and unpacking these are really important. I want to be clear that I think desolation is very different than depression. As a family doctor and sitting with others who know this, I still think the tools that Ignatius sets forth in times of desolation are good for everyone. Be with people, don't hide, don't do things in secret, practice the spiritual disciplines you know. Get yourself to church, pray the way you know how to pray. Don't make big decisions in desolation, this sort of sense that we are here together and be in community. So I think it's one framework, but I think there's a lot of that is super scriptural and Christ-centered and can offer some tools to consider in theology and mental health. Turn it over to me.
Thank you so much, Dr. Carlo. One of my greatest joys in sitting on these panels is because I get to sit next to really smart people and learn all sorts of things that I wouldn't know otherwise. It feels like, I have a confession that actually feels appropriate. I'm sort of known to confess things. I think it just makes me more comfortable. But my confession in this is that I actually had no interest in being a psychiatrist. Like zero interest, actually. I went into medical school with an intention to maybe be somewhere between a OBGYN or a family doc or a pediatrician, with this intention to serve adolescent young girls. I grew up in Jersey City and in a community that was just taken over by early pregnancies and just not great medical care. And so my drive into medicine had a lot to do with coming back and wanting to serve that community and that population. And the vision of that happened in one of those three specialties, at least in my mind. And as I went through medical school, I essentially hated everything. That's the first part of the story. And really, when I think back on it in a more helpful and purposeful way, I really think it was actually probably more God stirring me, And God knows who I am. It has to be a strong feeling to take me in a different direction. I can't be that med student that loves everything and picks the right thing. I have to hate everything and love one thing for something to happen. But even with that, I really fought this idea of being a psychiatrist. In fact, it felt insulting when people would come to me in medical school and, would kind of sit down with me and ask, what are you thinking? What are the things that you like about medicine, blah, blah, blah. And I'd say, I enjoy being in it with people. I enjoy sitting there and talking through, the child who's come in for the third sickle cell crisis. I want to know about what's happening in school and what's happening at home. And I was sort of stuck in that space. And every time someone would say, have you considered psychiatry? I'd just roll my eyes and be like, I came to medicine to be a doctor, actually, not not this hocus pocus, whatever psychiatrists do. And I think it's really important because, and I say that to level this field of I am and have also had to really battle my own biases about what mental health is and what mental health means. And obviously to become a psychiatrist, even understanding what that intersection looks like with my faith, right? I mean, by the time I got to medical school, I had already met Christ. This wasn't a question of, there wasn't some big revelation, and then Jesus came down and was like, you love me and you love mental health. It wasn't like that. I'd already loved Jesus. I still wasn't caught up on the whole mental health thing. It was a really hard concept for me to understand. But when I did my rotation at Jesse Brown VA in Chicago, which also I was really annoyed about that, because again, I said I wanted to do adolescent young girls and everything just kept pointing in a different direction. I really just could not fight the almost relief and comfort that I felt in sitting on those inpatient units and having conversations with these vets and talking through PTSD and depression and anxiety in such a way that obviously I became a psychiatrist. And so getting over the first hurdle of even is mental health a real thing generally was my first, that was the first thing, right? Then it became, oh gosh, the church. And Detmer can tell you, when we started having conversations about me coming to Lawndale, I was like, here's the thing. I now have caught up to the fact that mental health is a thing, and I want to be able to practice psychiatry I'm really not sure that I'm feeling it in this Christian clinic thing. So how about we have a conversation as to what you're expecting of me and how I feel like that might measure up or not. And in full transparency, my fears were that I was going to be trying to treat patients and people were going to be on the other end telling me that, well, you don't need to do it that way. We just need to pray more about it. Or it would be really unhelpful if I'm sitting with my patient and having a conversation about a primary psychotic disorder or working through medications, and then they see their next provider who is, giving them conflicting information based on a very well-motivated and understandable point of view. This was my fear. This has not been the case. Let me make that clear. That is not what Lawndale is. These were my fears, though. And that's because this conversation of mental health in the church is one that has been just fraught with a lot of tension. It's really hard. Where is the line that is, I am faithful, but I'm hurting. I trust God, but I'm still hurting. And then what do we do with it? What does it mean to maybe take medication or see a therapist or not, or pray or go to Bible group? And it's all very confusing. And I can't say that I'm particularly super, super well read on the different theories and the philosophies. I think whatever theology that I formed about mental health, it has been born of living life, just in my own experiences, but also sitting with people. And what I can say, and I can say very strongly is, I would say for every psychiatric concern, be it anxiety or depression, OCD, schizophrenia, bipolar disorder, you name it. In the same way that I feel for pneumonia and asthma and diabetes, there's absolutely a spiritual working behind it. And that's just because God didn't create, creation wasn't made for unhealth and things not to feel good and suffering in that way. So if pneumonia could have some sort of spiritual force behind it, because there is a spiritual realm, and as much as there is ours, then wouldn't that just be the same thing for depression? And so if I can look at pneumonia and I can give an antibiotic and still hold a space for the fact that there is a spiritual force at work, then theoretically I should be able to do the same thing with depression. But it's hard cognitively, right? Because pneumonia feels concrete. You look at the x-ray, you see the things, all the opacities, and you can be like, oh, and then I give you this thing, and then it goes away, and it's tangible, right? My feeling is not tangible. My feeling, I wish sometimes a little bit actually that we could take a lab and see what level of depression are you and which medication would this match with, right? We can't. And I think in that uncertainty and in that piece that is not tangible is a place where it actually becomes really hard to draw this concept. But I don't think it's actually that complicated. I think sickness is not of God in any form. And God in his grace has given us some insight, a little bit, into ways for us to help each other along in suffering and sickness, be it the insulin or the inhaler or the antidepressant or the antipsychotic. And I think that's kind of where I've landed. I often joke that psychiatry is a very humbling profession, and I think it's the only one that God really could give to me, because he knows that my head can get big really quickly. I can get really excited about how great I am. And if you made me a trauma surgeon, are you kidding? I would be just telling everyone the stories about the life that I saved today, and how amazing and wonderful it is. And psychiatry is this very slow burn, right? It's this walking and journeying with people in a way so slowly that when we get to a point of achievement sometimes, I honestly, was it my medication or did the sun just come out? I'm not really sure. But we're going to go with it, right? Because again, the value in it has not so much been the intervention as much as it has been the relationship and the being with and our ability to do that. So I think as I have I walk in this professionally, this is my 9 to 5. My theology has lived in this space of, God made earth and God made us in creation for good. Anything that's separate from that is not of God, but God also gave us the graces to be able to be with each other, tools to be able to help each other along. I think one of the most powerful ones is the being with and the relationship tools. And then we've got our medications and the medical devices and all these other things to sort of, further us along the way.
All right. Thank you so much for both of y'all sharing and hearing some of your stories too. When I think about mental health and theology, there's several things that come to mind, but the first thing that comes to mind is just thinking about my own story, and similarly growing up, thinking about my church experience growing up and having memories, understanding now of like having depression in childhood, but not knowing that and not having language for that and not having a space definitely in church or with church leaders to be able to talk about that. And so when I think about theology, mental health, I think about the pain of mental suffering compounded by the pain of not having a community within which healing can happen. And so, and then the stigma or the narratives that might get shared in particular spaces that could be the actual source of healing for people. And so that's the first thing that comes to mind, is just my own journey with that. And then secondly, I think about work in medicine. I'm a family doc, but there's a lot of days where I think I wish that I had some psychiatry residency because I don't have a psychiatrist to refer to. And so what's my role here? And so the challenge of working in primary care and in a lot of the spaces where many in this room work, sometimes you're tasked with caring for people when it feels like it's beyond your skill set. And that's really hard. And so still having those conversations about, well, where's this patient coming from? What are their beliefs about what's going on? What is mine to do? And at the end of all of that, I think the most important thing that we have is our presence. And so I had to deal with a lot of the anxiety of, I need to know the right thing to do in every situation and have the right diagnosis and and if I can't refer, then feeling this huge weight of responsibility of me again, and I'm like looking inward, like I'm looking at me and what's my role here, and instead of thinking about the person in front of me and their story and the community that they have and the other ways that God is maybe working in this moment, and there's a role for me, but I'm not the answer to everything all the time. And so having that humility of, okay, how do I discern what's mine to do here? And I think that the third thing that comes to mind that's complicated that for me further is, the influence of Dr. John Perkins in our family's life for the past 10 or 11 years. We've tried to pursue the type of proximity that Dr. Perkins preached about. And so for our family, some of the spaces where we're encountering mental suffering and mental health challenges are in the lives of our neighbors and friends over time. And so, I think of a dear friend right now who has been intermittently unhoused for the past 30 years. And just getting to know him and his story and through friendship, learning about how he started hearing voices when he was 9 after he watched his mom murdered. And hearing pieces of his story that he would share with us in friendship that may not get shared in the clinical setting because he knows the stigma that might get associated with things that he might admit to, or if he talks about thoughts of suicide. And but over time, getting to know him as a friend, and I think of many other friends over the years, it's shaped how I think about mental health from this way I've been trained to categorize and get all of my list of symptoms so that I can put into a neat category. And that's just not always how it works. And so getting to walk with people outside of the clinic and seeing them on the days when the sun is shining and seeing them on the days when the voices are saying really hard things and he doesn't know what to do about that. But getting to be present in ways that I can't in the system, inevitably because of where I work. I end up coming through the system, our healthcare system, and I had this moment where I was acutely aware of how the clinical gaze gets shaped because his chart came up and I got to see how the healthcare system views him. And it was a completely different narrative. It was really, really disheartening to see how the problem list comes up first. And you just see he's been reduced to these sets of problems that are unmanageable. And you see words like non-compliant and stigmatizing language around substances and things. And it really broke my heart to think, this is a really unhelpful way to see this really amazing person who's a friend. And so when going back to the very first things that we talked about, when I think about mental health and theology, we need a theology of presence, and where, there's power in language and in naming. And sometimes that can be really helpful when you're having a really disorienting experience or mental health challenge. To have language, a diagnosis can be helpful in some ways. Like this gives language for something I'm experiencing that's a description, but it can also be limiting and it can be stigmatizing, and it can narrow, it can change how we see each other, or how someone feels seen or no longer seen. And so I think there is power in using language and names where the names that we use are names like friend instead of someone with schizophrenia or living with this diagnosis. So when I think about the church's role in theology, like in what ways are we as the people of God befriending, knowing and being known in the midst of mental health struggles? Because the reality is probably many of you in this room, if you haven't already, like you're gonna walk through some valleys and some shadows and maybe some really, really hard things. And if not you will walk with others. And so what does it mean for us to be the kind of people who can be present without having to fix all of that? And hold up the kind of, when we don't have the faith to believe, to be cared for by others who can hold a little bit of faith for us. When we're maybe trying to pray and we don't hear from God, and we're trying to remember what it felt like to hear from God. These are really hard things to hold. And so the antidepressant there often is community and presence. And sometimes it's medication. It's not always just one silver bullet right there. There's a myriad of ways that we can be present to people in our clinical roles, but also in our communities and in our churches. Those are the first thoughts that I have when I think about mental health and theology.
Thank you. I like Louisa, benefit from these. It's just fantastic. One of the things I've learned about over the last many years is this idea of theology of presence, and I think all three of you talked about that, but I wonder if somebody could just make it real simple for those of us for whom that's the first time we've ever heard those words, theology of presence, and what that means. Can you talk about that? I remember probably 5 years ago or something, I was on the phone with Dr. O, and I said, oh, by the way, she wasn't kidding about the meetings that she had before we got her to come on. It took hours to convince her that, we didn't have to baptize everybody before we saw them or whatever. But I remember asking her this question, and one of our other psychiatrists, I said, if you only had two tools in your toolbox as a psychiatrist, medicine or therapy, which would you pick? And she thought about it for a second. She said, I've thought about this for a while. She said, I think that as I consider my work as a psychiatrist, the thing that maybe is the most important that I bring to the encounter, she said, medicine has its place, can help people get sleep. I remember what you told me. You said, people are hearing voices, it's nice to be able to sleep, to calm the voices. Therapy has its role too. She said, I'm pretty sure that the most significant thing that I bring to the encounter is that one person, that my patient knows that there's at least one person in the world who cares, whether they're alive. So that to me is something about the theology of presence. So I'd like somebody to briefly just lean into that a little bit more and talk about what does that mean? Because it seems a little, whatever, like, oh, whatever, yeah, but give me the Haldol kind of a thing. Like, theology of presence is a real thing, and I want to lean into that. Even Dr. Carly, you talked about Ignatian spirituality, and it reminded me a lot of Henry Nouwen's thinking about, okay, so step one is to know that we are God's beloved, but then the rest of your life, the world, the devil, your own mind is going to tell you you're not good enough, you're not smart enough, you're not pretty enough, you haven't achieved enough, you didn't become a trauma surgeon, right? And so according to Nouwen, one of the great challenges then of even once we become believers is how do we create practices and put ourselves in places where we aren't battling all of those thoughts on our own all the time. So that's sort of my opening is somebody talk about theology of presence and then practices.
A simple verse that I don't know if Brett McCarty is here, but we're going to touch on this tomorrow. But in Acts when Paul is imprisoned and the chains fall off, and the jailer is about to take his own life because he realizes he is in big trouble. And the response is, do not harm yourself. We are all here. And I think that is a really important framework for thinking about this, particularly around mental health. No one that we see walks into the exam room alone. They've got a community out there behind them in some way. And I can't be presence for everyone, but I want to help those that I am in touch with find out who their community is, the people that are like, do not harm yourself, we're here. And unfortunately, I think medicine has a history of wanting to solve things quickly, and perhaps particularly in psychiatry, we know that that's it's a lifelong journey often. There's also a mental health course out of Canada, out of Vancouver, called Sanctuary Course, a mental health for clinicians and churches course. And the framework for that I have held is that anyone can be languishing or flourishing with or without a serious mental health diagnosis. So it's all a spectrum, and we are here together. And labeling someone as actually someone who lives about a block from me who I think pretty clearly has schizophrenia, but I know him as the guy who's always out planting and replanting things, and we have conversations when I'm walking my dog. He clearly has something that I'm sure is a diagnosis going on, but our relationship is about those plants, and he is part of my community in that kind of way. So to see people in the bigger framework, to use medicine and the gifts that we have in medicine, but also to realize there's a lot that we all carry our whole lives that are only variations on that. So that is my little verse around presence.
When I think about theology of presence, there is a challenge in our healthcare system in the hyper specialization and the ways that we've increased our technologies and our trust in those technologies that in some ways can undermine the community practices that help keep us well. And what I mean is I'm thinking of a number of patients who I'll see in clinic who are having some severe mental health challenges, and I'll ask about their community and how they're coping with this and what that journey's been like. And inevitably they'll talk about a point at which their church, their community, their friends, or their family could no longer be present. And they said, you need to see a professional. And that's why I'm here. And there's again this grief of like, it's not bad to have professionals in healthcare. We're all here, right? There's something about this that we think is good. And also theology of presence is, what does it mean to care for someone when there's not a cure and when there's not an answer or a fix? And what does it mean for us to be the kinds of people who maintain presence and care when it's really hard and when it costs us something and when there may or may not be a professional service or solution to pursue? And even if there is, how do we still maintain presence with one another in that?
I'd add that one of the hardest parts about being present and staying present is fighting our own anxieties about, well, what we can't do, frankly. It's that wrestle that I have having to remind myself. And I often say, I came to Lawndale because I had this desire to serve a population, to serve a community. I stay at Lawndale because I can walk out of a room and have a colleague remind me, that's not your job. That's God. We leave that part to God. We do what we can do. And this isn't on you necessarily. And those reminders are so necessary for me in my work, but it is one of the most difficult things to sit and be present with someone, not have an immediate fix for all of the other things and contexts. There are patients that I can think of right now that are struggling so much. And I know if they could just have stable housing, that could actually alleviate something pretty significantly, but I can't make that happen. So sitting with those anxieties can be so, so difficult. And I would argue, I mean, with the work that I do, there has to be a way that I can get home to my husband and my 3 kids and not just be so heavy with everything, and I think God has graced me with some ability to leave work and go home. But the patients that do follow me home time to time, the ones that kind of wake me up in my sleep that I'm thinking about in the middle of the night, those are the ones that don't have anyone out there. And I think that was such a I don't know, just a surprising and shocking in some way reality for me in the work that I do, that it is a thing that there are people that have no one. And that concept is very hard for me, who comes from a family, mom and dad and siblings and church family and neighbor. I mean, my networks, by God's grace, there's just nets and nets and nets and nets. But people have no one, 0 people. And so they walk into a clinic encounter, or they walk into our clinic, and the experience that they have from the registration person that's hey, Miss Mary, you look great today, to the one that they have when I'm sitting in with Miss Mary, that is their community. That is their community. And then they leave that, and I'm thinking, oh boy, it's just us. I mean, if there were a way to, which I'm sure there is, and no one do it at Lawndale, but if you could go through my in-basket messages from my patients, certainly I have the ones where people are asking me questions in crisis, or everything's going terribly. But then, no lie, and my team can attest to this, I've got selfies of great day today, Dr. O, or I've got, hey, just wanted to update you. I did so well on that test, whatever. And then I'll say, so proud of you. All of a sudden it feels like I'm becoming the auntie and the cousin and the sister and the whatever. Those are the patients. Those are the ones that wake me up in the middle of the night that I'm oh, but I can't actually be that for them. They can't actually have my number or come over for dinner. Mm-hmm. But this space that we create to be present with them, that's what's carrying them. And that's a very anxious space, admittedly, for me to occupy, because I know that this space is going to last a whole 45 minutes. I could stretch it to an hour, maybe. I might be a little bit behind, but I can give you, and then you're off to the rest of your world until the next appointment.
Okay, we're going to take it to the next level because we're getting close, and Dr. O said something that made me want to tell a story. And I know that many of you are here because you just care about theology in general, and you're interested in theology of mental health as you're interested in theology of everything else. I know a lot of you are here because you're practitioners, and when I say practitioners, I don't just mean clinicians. I mean everybody Everybody's here as the whole team. At Lawndale, that's what's special about that place is as Dr. O said, we know it's not just the provider, right? Sometimes it's the registration rep or even the operator on the phone. I've had patients tell me that. I came in here just to see if this is the real deal because of the way I was treated for the first time with dignity on the phone. So it's a team sport. But it's not just patients who are homeless or who, that's sort of the stereotypical ones that we think of. I'm going to tell we have over 100 providers at Lawndale, and a few years ago, one of our providers got sick and was in the hospital, and she called in to our Jessica, who's now our director of HR, and she said, it's okay, we're going to be, and who do you want us to call, when, and the doc said, there's no one. I have no one. It's a doctor at Lawndale. We had no idea, right? So the group in this room, some people just care about theology in general, some people who are practitioners, and then most of us are here because we're all have mental suffering, either recently or right now. So I want to ask this group, as Christian people who work in this space, what give us some hope here. Give us some practical things to think about as Christians, but also as clinicians, those of us who may be suffering currently or who have people close to us who are suffering. Give us a word today.
I feel like we live in America in a culture that encourages isolation, and that is modeled for us by the walls that we have, the ways perhaps choosing an email response as opposed to direct conversation can be seen as easier. I think COVID made a lot of this worse. So that story is a hard one to hear, and yet I believe it's true. And it might even be true of people in this room. And it's hard to move out of isolation and loneliness when you are most feeling the need for others. But again, I would lean on the practices of the church to get to church, to choose to worship, to reach out, and just start there.
So I would dare say that for anyone, it's not actually true that you're all alone. And it's an important message to hear clearly, because whether it's the voice in your head, the feeling in your chest, the family that's cut you off, the whatever, it's not actually true. Because you're not all alone. And then the next step is the work to figure out how to feel, how to get in touch with whatever that is. And we're not all alone. We know this in this room, right? Because God is with us always and always and always, right? But that's also not very tangible when I feel terrible and all alone. And the next thing that I would say is it's so important then that you share that you're all alone. Because one of the biggest things of isolation is this inability and fear of opening up this vulnerable space to let people know that it's what's happening, be it because it looks weak or they'll think differently of me. And the thing is, time and time again, I have been so wowed, either in my personal life or in the lives of those around me, in how powerful it is for someone just to speak the thing. To say it out loud for someone else to say, oh yeah, me too. Or I know a person. Or actually, then why don't you come with me? But the thing is, we can't actually, God's gifted us with a lot of things. Telepathy isn't one of them yet. Maybe one day. Not something that I've got. And so part of the work is not only to fight and kind of try to work against this idea that you're all alone, but also this idea that you're supposed to be quiet about the fact that you're all alone. It's the way that I meet my patients, right? Because for every patient that I see that I can sit and be present with because they're telling me a thing, there's someone else who's lost their life that said nothing to no one, or no one noticed. And I would even take it a step further, because we are humans, and we have feelings, that if the first person doesn't give you the response that can help you get in touch with the fact that you're not all alone, it's that persistence to go to the next person, right? Not to take that one as the response for all people, because I'm saying very categorically, you are not alone, and that there are people. There is a God, and there are people that want to be with you and want to be able to walk with you.
Yeah, I'll echo that. You're not alone. I know enough people here to know that if you're feeling that, there's someone else here in this room that has walked through that. A feeling alone of wanting to be out of this place, to leave, to retreat. I was there a few years ago, and I hear a lot of language around not wanting to be a burden for others. Everyone else is already carrying so much. I hear this from patients a lot. But one thing that I've learned is that by not offering that vulnerability or naming things that are really difficult, I'm also denying the body of Christ to be the body of Christ, and to denying their ability to love. And we're a people called to love. And so sometimes that means we get the turn to be the ones who receive that love. But we can't always do that unless we name our need. And there's a vulnerability there. But there's also a great opportunity for God's grace to be demonstrated in each other. There's the sanctuary course you talked about. They partnered with Porter's Gate, which is they have an album called Sanctuary Songs, and so it's songs about mental health and theology. And there's a song in there called "Sing Over Me," and the chorus is a question about, will you sing over me when I've forgotten who I am, when I can't keep doing this? There's this language of I can't keep doing this, but will you sing over me to remind me, sing the tune that I can't sing? Like sometimes we have to sing the song for each other. And there's a part in there that says, and one day I'll sing for you. And so I pray that we would be those kinds of people that when you can't sing, when you can't pray, we have a cloud of witnesses. We have prayers of others that we can join in even when we don't feel it. And God is with us, and we are not alone. Yeah.
Thank you. We're going to open it up for questions in a minute, but I want to tell you that the most beautiful part of the story about the physician was that Jess said, "Yes, you do, Doc. You have me." She said, "You have me." The thing that I've learned a lot in the last year from a book. We always like references and things and resources. And so I'm going to shamelessly plug a book called On Getting Out of Bed, The Burden and Gift of Living. It's by an English professor of all things from Oklahoma Baptist University. And I don't feel bad about sharing it because I've probably given out 70 copies of it in the last year. And even at this conference, one of my brothers came up and said, "Dude, I just read that book the day before I got here, and I'm changing my workshop tomorrow based on what it said." It's a book that just sort of treats mental suffering from a distinctly Christian perspective, but without dismissing all of these other good things that we talked about. But I think one of the things that he talks about in there is first of all that it's incredibly common, but also that he doesn't try to figure out these things that have bunched us up in the past about is it the devil telling you this in your mind? Is it a chemical? Is it your own mind? Is it the world? Whatever. He just says all four of them. He says, whatever it is, this is the thing that's going to happen to you, right? And so then he talks about how, and he uses the metaphor of getting out of bed as as a way to think about that, because he says at some point, most of us, at some time in our life, will wonder whether or not it's even worth getting out of bed, whether or not life is worth living. And he talks about how this simple act of getting out of bed is an act of bearing witness to something, and it all relates to the fact that we believe we're all created in the image of God. That's the key to the whole thing for me, is we may be somebody struggling with schizophrenia, we may be struggling with depression or whatever, but at the end of the day, the reason that we have the reason we have dignity is because we are a child of God, created in his image, full stop, right? And so, so that was a helpful resource for me. We have a few minutes left. We're gonna open it up if anybody has any questions for the panel. We can take a few questions.
Thanks, Joe. I appreciate hearing the themes of loneliness and community and contemplation. And I want to mention to either of you who want to answer this, but maybe to turn it on its head. I hear often, I don't want to be alone with my thoughts. And I think for each of you, you kind of named this spaciousness to be able to think about what's going through and then share that and mean that. And so I'm wondering, how can you encourage folks to be courageously alone with their thoughts, to be able to ponder more, to contemplate more, and then take that step of getting help or sharing that with the community? What would that look like? Especially in our fast-paced society, we're busy, we go to the phone, we do numbers stuff without really thinking about what's happening here.
Can you repeat the question, please?
Thank you for the very long question to repeat. No, that's great. Thank you. So the question is around loneliness, but also contemplation, the courage to share with others, but also how do you think about the space of being alone with your thoughts for actually making that space for contemplation? So, spiritual practices of silence and solitude are really important and have become increasingly important for me in my own spiritual practices. But I'll be honest, there was a point where practicing silence was really distressing, because once I was still and quiet, all the stuff that I had worked so hard to be too busy to feel started to come up, and it was terrifying. And so when I talk about spiritual practices with students or residents and who want to enter into that, I name that from the beginning, that it is good to have space for solitude, because sometimes that's the only space where those things can come up for God to be present fully to and deal with those things, and for us to even be aware of them. But to know you may just have to start really small. Maybe just 30 or 60 seconds of silence might be a first start. And then you can slowly build to that practice where you can give more space. And as you feel those anxieties, or if you've experienced trauma, for example, that may be a very unsafe space. And so recognizing if you're feeling unsafe, that might be a clue to reach out for help with some professional help or with trusted faith community to help be present with you as you're trying to cultivate some of those spaces for contemplation.
Thank you. Another question?
Okay, so I've got 3 questions. This my brain is just going. One, I'll say this: social media is everybody's favorite zone.
No.
So I got pictures, and I even before I came in here, there was something on TikTok, and it was giving 7 daily habits to do. And then as I wrote them down, because I was like, oh, this sounds great. And then as I was listening, I was like, wait, that doesn't really line up with what you were saying. So now you have people that they depend on social media for their mental health. So that's my first thing. And then second, I do work in public health, and I think everyone deals with something. I think some of us are functional depressed people in the sense of, we deal with things, but because we're able to get through it, then we don't have a label. We don't necessarily have to name it because I'm okay, and because you're functioning, you're able to go to work, you get up, you smile, Then you go in that corner, and sometimes you don't reach out. You know, when you are having those moments, and those moments seem so deep, and then you come out of it because you're functional. You have those people. Now I forgot my third one. Lord have mercy, my mind is going so much. Oh, and what you said about going and seeking help. Sometimes people, if we don't get the answer that we desire, then we stop. Or if we get the answer that we think we want or a person wants, then we think the answer is correct, when it's actually not what we needed. So anyway, those are my 3 points in this.
So the comment was about social media and that being a source of mental health information and practice for people. The second was being in a state of maybe depression, for example, but you're functional, you've learned how to manage and do the day-to-day, but there's a level of suffering there that's maybe not fully acknowledged or dealt with. And then the third is when you're reaching out for help and you may not get what you want to hear, so you dismiss it or stop seeking help, or you're looking for something and you find it when it may not be what you need. Is that right?
Well, the third one is you want what you want to hear, but
Yeah.
it's not what you need.
Right. Yeah, it's not what you need. Thoughts?
My thought is yes.
Thank you.
That's about that. Yes. I mean, and it's in all things. Yes. And here we are, right? Still just trying to work it out.
Any final thoughts? I think that's our time, but I want to thank our panelists for graciously doing this, and what a privilege it is to sit in these spaces and to have these conversations and to tell the truth, right? That's what we're here to do as the church, is we're called to tell the truth. And so as we name these things and start to think about mental suffering theologically, I hope that part of what we're doing is telling the truth.